Sir, my slides are visible. So chronic orcalgia is defined as 3 months of intermittent or constant testicular pain that is bothersome to the patient. It is the cause of about 2.5 to 5% of all urology consultation and currently affects about 100,000 men in United States each year. When it cannot be directly attributed to any specific identifiable source, it is called as idiopathic. Unsuccessful recognition of the origin of testicular pain and a high failure rate of surgical intervention leads to poor outcome, psychological stress, and increased cost of care. So globally, health outcomes among men are poorer than women, and very little efforts have been made by health organizations to promote men's health. Testicular awareness is an all-encompassing concept since it helps men become familiar with the body part that is seldom discussed and enable them to detect testicular abnormality and to seek timely medical attention for testicular symptoms regardless of the ultimate diagnosis. Researchers, mainly randomized controlled trial in this particular field, are very less because of the sensitivity of the issue. People usually avoid this until unless it is interfering with their ADLs. Recent discussion in the physical therapy community have been targeted towards addressing the thoracolumbar spine, hip flexibility, and lumbopelvic muscle control in patients with chronic orcalgia. The need for evidence to support these interventions is apparent, though the increased use of manual therapy by practicing therapists globally. This single case study opens up a totally unique perspective for the awareness and treatment of orcalgia. Now coming on to my case description. This is a case of 25-year-old software engineer in a Pune-based MNC. Due to the onset of this pandemic, COVID-19, the patient shifted to his hometown and started working from home, 9 hours a day, evening shift. Before lockdown, patient was having an active lifestyle, but after the onset of pandemic, patient shifted towards sedentary lifestyle. Mr. X was having a complaint of bilateral testicular pain for a year with left side dominant than right side that began in September 2020. Onset of pain was sudden after riding a two-wheeler on a rough road. Mr. X had many risk factors. BMI was 29.411, history of neck pain and back pain, and increased lordotic curve, lumbar lordotic curve. The main part of this investigation of this case study was that for 1 year, that patient had been to 3 different urologists, and they all diagnosed totally different things. On 8th October 2020, he went to a urologist and had his scrotal USG done, and he was diagnosed with left side grade 1 varicocele. On 30th Jan, due to non-resolution of the problem, he again went to some different urologist, again got that scrotal USG done, and he was diagnosed with left side grade 2 and right side grade 1 varicocele. Then again on 17 September 21, he went to a third urologist, got a scrotal USG, and was diagnosed with bilateral subclinical varicocele. Urine routine was done, it was normal, testosterone total was done, it was within the range. Patient also gave history of uroflowmetry done in April 21. Urologist diagnosed epididymitis and medication for the same were given, but reports were not available with the patient. So these are the images of the diagnosis of ultrasound report. Left side grade 1 varicocele, left grade 2 and right grade 1 varicocele. So after the non-resolution of the problem, the patient came to physical therapy OPD, and after that we started our intervention. Our main focus was not on testicular pain, but it was our assumption that it might be a referred pain. So just for this, we chose 2 different outcome measures: pain impact questionnaire, PIQ-6, and chronic orcalgia symptom index, COSI. Here you can see it focuses on 3 different aspects: your pain, sexual symptom, and quality of life. And the other one, it has 7 questions. in which we can check the scores. Now, physical therapy examination. On subjective assessment, the chief complaint of patient was testicular pain for more than an year, left side dominant. Initially, pain was sharp, but with time, a continuous low intensity pain was experienced by the patient. Present medical history, bilateral testicular pain. Past medical history, complaint of neck pain and back pain for 3-4 months prior to the onset of testicular pain. Now, objective assessment. The patient body build was endomorphic with increased lumbar lordotic curve. On gait examination, left hip externally rotated. On palpation, bilateral tenderness was present in trapezius muscle, paraspinals, quadratus lumborum, iliopsoas, and hip adductors. On examination, site chronic bilateral testicular pain, testes were normal in size, no swelling is seen, mild tenderness of both epididymis, and no pain in groin. These were the range of motion when we assessed. Thoroughly, we can see that range was slightly reduced, but hip flexion range was reduced to a greater extent. Active range of motion, left was 50, right was 60. Above this range, it was pain. So we have taken the pain-free range. Now, pain assessment, location, epididymis and gubernaculum. Onset was sudden, nature was continuous, type dull aching, intensity 2 when we measured on numeric pain rating scale. Then aggravating factors, the pain increase on masturbation by lifting weight, running, climbing, and relieving factors were lying down. Diurnal variations were not there. So the significance of this case was that for any particular individual who is about to get married, the persistent testicular pain of dull egg will have a huge impact on his psychological status. So physiotherapy assessment and goals: to reduce pain and tenderness, to reduce muscle tightness, improve range of motion and neural flexibility, to promote relaxation, improve mobility of spine, to modify the activity that provoked the symptom, and to regain functional independence. We divided the protocol into 3 parts. 3 months protocol was there, but the pain that the patient was facing, it got resolved in just 2 sessions. We performed dry needling on his hip adductors and paraspinals, and the pain was gone on the spot. But still, we designed this protocol so that the reoccurrence of the pain should not be there. So, first month, muscle release and flexibility exercise, we focus on active stretching and passive stretching. Passive was done by us in the OPD, whereas we advise patient to go for active stretching in the home. Dry needling was performed in the OPD itself for the trigger points that were present on adductor, piriformis, and paraspinal muscles. Calf stretching, hams, piriformis, knee to chest, unilateral plus bilateral, then cobra stretch, child pose, and pelvic roll. These all were given in the first month. Then second month, stabilization exercise. All exercises of first month were asked to continue. Along with that, pelvic bridging, straight leg raise, core strengthening, Superman pose, dead bug, cat camel. These all were advised on home. Because of the financial issue as well as for the continuation of the treatment, we advise patient to do most of the exercises at home rather than coming to OPD and paying for that. Then the third month, functional training. All the exercises of first month and second month, along with that foam roller release, because his back was quite stiff, and due to the sitting posture and all, we advised him foam roller. Jogging was advised to move him from sedentary lifestyle to active lifestyle. Then skipping was advised. The best part was that the patient fear to jump and all were overcome in the last 2 months. Then theremin training for hip muscles. This was advised. So the results were that COSI score before the intervention was 19, and post-intervention it has reduced to 6. And PIQ 6, the earlier score was 21, which is reduced to 10. Coming on to discussion, that despite of testicular pain being a common problem, there is paucity of literature at the global level. In current scenario, antibiotics and NSAIDs are being used as the first line of care by urologists and physicians. Surgical interventions such as testicular denervation and orchiectomy have been described as possible alternative when conservative measures have failed. Unrecognized testicular pain and a high failure rate of surgical intervention has a huge impact on patients' quality of life, leading to years of psychological distress and costly procedure which yield no significant result. When we were taking history of the patient and we asked about the fear, he was having a fear that he would no longer be eligible to marriage because uh, he don't want to disturb any other individual's life. So there were huge fears, especially in the population which do not have proper medical knowledge. Musculoskeletal structure can be at the root of testicular pain, and these are often overlooked in the medical workup, in which the physical examination is typically limited to the genital region with emphasis on the scrotal contents. Further down, the relevant branches of the genitofemoral nerve passes through the inguinal canal. Tension or hypertonicity in iliacus and psoas region can result in compressive force on the posterior wall of inguinal canal, putting pressure on the canal's content or on the nerves or vessels in the canal. In addition, the iliopsoas is facially linked to the other structure in the lumbopelvic hip region, such as hip adductor and pelvic floor, which can contribute to testicular pain. So, to conclude, the present study has found the effect of integrated exercise protocol in improving pain, spinal flexibility, functional capability, and quality of life, and can be used as treatment protocol for unspecified chronic arthralgia. In case of arthralgia where local causes of scrotal pain have been excluded, spinal origin of symptoms should be considered, and a thorough physical examination and imaging of spine should follow. Physical examination should include mobility of thoracolumbar spine, hip flexibility, and lumbopelvic muscle control assessment. In the future, efficacy of the integrated approach to a large sample size and in comparison with standardized protocol can be determined. So these are my references, and thank you.
Yes. Any questions? Any questions to Dr. Varun Haja? Just if you have any questions regarding this topic, you can text in chat box or we'll be asking behalf of you, even after the completion of the Congress.
You can also question me on my WhatsApp number or on my email ID.
Yes, sir. We do have your email as well as your WhatsApp number. Definitely, if we get any questions, we'll forward to all this information to you.
Sure, sir.
Thank you so much, sir. You'll be getting the participation certificate as well as booklet within 2 to 3 days.
Okay.
Thank you so much, sir. Have a nice day. Yeah. So, next speaker will be Dr. Isabella Stolza from German Sports University from Cologne from Germany. The topic will be translation and validation of ICF-based equidistant assessment tool for the measurement of equino assistant interventions in on international collaboration projects. Yes, sir. Dr. Ranu, you can start sharing your slide. Okay, that's fine.
Excuse me, madam. I didn't get your voice, madam. Please play again and yes.
Hello everyone, my
Yes,
name
okay.
is Ina Stolz. I'm a researcher at the Research Institute for Inclusion through Physical Activity and Sport and a lecturer at the German Sport University Cologne.
Please
Today
increase
I
the
will
sound,
present
increase the
our
sound.
international collaboration.
Please increase the sound. Sound. Yes, yes. Correct.
Project on the translation and validation of the ICF-based Equitedo assessment tool for the measurement of equine-assisted interventions. Equitedo is short for Equitherapy Documentation, and it's a digital therapy app that can be used and applied online. And I will start with a presentation of the digital app and afterwards show some key results and conclusions of our validation and translation study. The background of the study was that ICF-based assessment tools have been implemented widely in the international health and rehabilitation system since the ICF has been defined as a standard to assess a person's functional health status. The ICF is the International Classification of Functioning Disability and Health and is a core classification of the World Health Organization. It defines a person's health status based on the biopsychosocial model, which includes concrete ICF codes, concrete classification codes to define a person's status in regard to physiological, mental, and social aspects. And therefore, it's an international accepted holistic framework which can depict changes of the functional status of a person in therapy very precisely. And therefore, it's also suitable for the measurement of effects in equine-assisted therapy in a common international language. The background for that was that there is a large variation of assessment and documentation tools in the field of equine-assisted therapy, which depends on scientific discipline and country. For example, if scientists are observing more from a medical perspective or more from a psychological or social perspective of the therapies or the patients. Therefore, a systematization and comparison of international results is still very difficult. So for the measurement of equine-assisted therapy, the ICF as a framework to collect information and to create a systematization of the assessment of therapy-related effect factors is a very suitable approach. So the Equitedo app was created on a scientific process I will explain later, and Equitedo, as I said before, is short for Equitherapy Documentation and represents a digital documentation and evaluation tool for the assessment of different disciplines in equine-assisted therapy and to measure effect factors depending on different therapy targets and aims. It includes general aspects of equine-assisted therapy and also specific aspects, for example, the group therapy, single persons individual therapy, and the hippotherapy as a horse-assisted form of physiotherapy, focusing motor skills and physiological aspects. The utilization of the app is very simple. There is a concrete situation in therapy. For example, we have this example of a kid sitting on a horseback and doing a fine motor movement task. It's putting some show cards on the pad on the horse's back. The therapist watches and observes this situation and classifies the functional abilities of the child in regard to this concrete item, this concrete task, in the 10-point Likert scale in the digital assessment app via smartphone or computer. And afterwards, this concrete item can be linked back to the ICF. In this case, the fine hand movement task is depicted by the code D440, fine hand use. And every item in the app can be linked back to a concrete ICF classification code. Now I want to give you a short walkthrough through the digital assessment app. At first you see the landing page where you can put in your email and your password, and then you get into your personal account with your dashboard where you find all your clients, your reviews and appointments. Also you find your therapy focus and weekly workload, and can organize your weekly appointments in a calendar function. Can also organize your clients, and you have a digital patient record for every client where you can classify the forms of disease and disability, and also can put in your mean values of the assessed functions. You can print a PDF where results of therapy are automatically analyzed, and you can print this result and give it, for example, to treating physicians, to therapists, to the clients themselves, and also to funding agencies. You can view your reviews of your assessed patients. Also, you can create invoices, write invoices for patients, for funders, and put in your therapy. And also you find a test manual for the app which explains all items and all linkages to the concrete ICF codes. The main function of the app is the automatic result function, where you can see your weekly stats of therapies in the course of time of therapy, and you can define your therapy progress per assessment and also per item. After therapy is ended, you can generate a confirmation of participation for patients if you want, but the main function of the tool is the automatic evaluation function. And this function allows you to generate results of your therapy in one click. You can generate mean values of test items, of scales, and also modules that map, store, and statistically evaluate your therapy progress, your therapy results. And these results can be downloaded as a PDF report that can be passed on as a final or interim report to clients, to cost units, schools, physicians, or health insurance companies, and also can be used in terms of therapy funding. And in addition, also own texts can be formulated to depict individual aspects of therapy. Coming to the scientific process of the development of the German-speaking assessment tool, the Equiteto tool is a result of an extensive and scientifically high-quality mixed methods research process over the past years. The duration of the study was 2 years and 4 months, and there was a German-wide multi-center study with 876 therapy assessments of in total 265 clients by 30 participating therapists. And before the assessment tool was trialed in therapeutic practice, there was an instrument construction phase where 17 experts from different areas of equine-assisted therapy conducted therapy aims, therapy targets that were linked back to the ICF to define a suitable connection between the ICF and the aims and targets of equine-assisted therapy. And afterwards, the pilot tool was trialed in therapeutic practice. It was modified and reduced according to therapists' feedback. And the final instrument, the final assessment tool, was then tested in regard to its psychometric properties according to scientific quality criteria. The results provide strong support for a targeted and economic assessment of equine-assisted therapies via the scale structure of the developed basic module and also the subscales. The procedures to test the validity, objectivity, and reliability of the German language tool have shown satisfactory values and confirm the suitability of applying the ICF classification system to the holistic aims of equine-assisted therapy. All modules are characterized by a high degree of reliability in the subscales and global scales, and all test items can be related to the international health-related domains of the ICF. I have 3 example items here to give you an impression on what we measure with the assessment tool. The item G17 focuses mental functioning, and the item is the person or child can memorize processes and tasks in the therapy and reproduce them later, and it's the concrete ICF code B1442, retrieval of memory. The next one is G24 and is in the area of motor and perceptual aspects. A person or child can feel vibrations on the horse's back, and this is the code B2701, sensitivity to vibration. And the last one is more in the psychosocial functional area and is the item G15. A person or child can show consideration and tolerance and react to these, which is the code 7102, tolerance in relationships. And after finalizing the German language tool, it was subsequently translated according to the TRAPPED guidelines by 2 independent translators. The TRAPPED methodology includes translation, review, adjudication, pretesting, and documentation. And I will walk you through these steps. It was originally developed by Janet Harkness in 2003. Is also described, for example, by Burr, Brown, and Dora in 2015 in the Jesus Survey Guidelines for Measurement Instruments in International Studies. TRAPPED is an acronym formed by the different steps of this procedure. The T, translation, is in this case the first step, where 2 independent translators create each a version of the new language instrument. It is recommended that at least one of the translators is a professional translator and has a degree in linguistics or linguistic studies. The next point, R for review, stands for a subsequent meeting in which the 2 independent translators discuss their versions with a reviewer and, if possible, work out a solution for each questionnaire item in the new language. In the next phase, the adjudication, any ambiguities or open questions are raised and discussed after the review step, and also unclear aspects are to be clarified with the reviewer. In the next step, the pretest, the instrument is to be tested on a small sample of the target population in order to assess to what extent the translations are understood in the intended way in the practice. And in the final step, D, the entire process is documented and the final translation is done and tested in the target population field. And in our case, we had another step, and we also linked the instrument to, in this case, for example, the Spanish version of the ICF by both the translators to make sure that every test item which was linked to the ICF in the German version of the ICF is found and relinked to the Spanish version of the ICF after translation. Afterwards, the instrument is to be trialed in 2 validation trials in the English and Spanish therapeutic practice. This is what we are conducting right now. We are doing 2 cross-sectional surveys with a sample size of proposed 340 clients and participants, and the statistical procedures to be tested are tests on construct validity, concretely conformatory factor analysis are to be conducted, and tests for internal consistency. Also, the reliability is to be tested after the trial is completed via retest and inter-rater reliability. Also, the test sensitivity is analyzed subsequently through mixed linear models and multi-level analysis to clearly analyze if the tool can depict changes in therapy and progress in therapy sensitively. If you are interested in the publications of the survey developments, we have a lot of publications. The last one is an open access publication here, the Stolz, Anneken, Froböse 2022, where all these validation procedures and statistical steps are explained, and the construction of the original assessment tool is documented very precisely. Coming to the conclusions of our trial, the research approach has proven to be a valid method to develop an internationally compatible assessment tool on the international common basis of the ICF of the World Health Organization. It can make data material from different language countries comparable to each other, and prospectively the instrument will contribute to creating increased transparency about therapy effects and also effectiveness factors of the therapies for cost bearers and also for clients and service providers. Therefore, we hope that the developed international versions are used in therapeutic practice in a large way, in a large amount, so we can generate large data sets and can analyze effects of therapies and targets and concrete effect factors more precisely on a basis of larger sample sizes. Coming to the perspectives of the studies, right now the Equitido app is available at www.equitido.com. Also, the test manual is free of charge when downloading the app. Unfortunately, we have it ready in German language right now and are busy with the international translation processes. We don't have a Spanish and English version of the test manual ready right now, but we are intensively working on it. Also, we are planning an efficacy study in a randomized controlled trial study design, which starts in 2023 in Germany. And in this study, the assessment tool is to be trialed in a large multi-center study. So this is my last slide. I want to thank you all for listening, and if you have any questions, I'm happy to answer them. And we are also searching for international collaboration partners in English-speaking countries for our English validation trial. So if you are interested, or if you want to get more information about it, please write me an email or visit our website www.equitido.com. Thank you very much.
Yes. This was a presentation from Dr. Isabel Stolzo. If you have any questions regarding this topic, please, you can ask questions. Madam is in online. Any questions? You are supposed to be in Dubai, madam. Due to other consequences, you are not in Dubai. You are supposed to be your present yesterday talk. Yes, yes. Just unmute yourself. Yes. This was the presentation from Dr. Isbahal Stores. You'll be getting the participation certificate as well as booklet within a couple of days after the completion of the Congress. Thank you. Thanks so much, madam, for joining this event once again. And we'll go with, we have three more talks for the end of this session. Next, we will ask Dr. Sohail Mansoor Sohani from Iran University of Medical Science, Tehran.
Hi.
To start the presentation, sir. How are you, sir?
Hi. How are you?
Yes, I'm fine, sir. Yes, sir, you can start sharing your slide. Yes.
Okay. Please share my slide and start my presentation. Can you share my slides?
Yes, I'm going to slide.
Okay. I'm waiting. I'm Dr. Sohail Sohani, PhD in physiotherapy, and want to present for you light therapy in neuromuscular skeletal pain. Please change my slide. Light therapy, the energy of life. Biotron light therapy is characterized by polarized, polychromatic, incoherent, low energy, and biostimulation of tissues and cells significantly reduce healing period, medically proven effectiveness, unique success confirmed by clinical studies. Please change my slide. Biotron is produced by hyperpolarized light, opens up unlimited possibilities in treatment and prophylaxis. This is an exciting new field in biotron. Biotron produced by halogen lamp. Halogen lamp is produced diffuse light and reflect to Brewster mirror produced polarized light, and by fluorescent material transferred to hyperpolarized light. Please change my slide. Next slide, please. Absorption of biotron light and color through the skin from 0.5 to 3.0 millimeter, from infrared light to visible light. Biotron characterize. Okay, thanks. How does biotron exert its biostimulated effect? Biostimulation effect characterized by polarization. Polarization means ensures optimal light penetration through tissues, biostimulating the immune system for faster and more effective healing. The second character, low energy. Low energy means it stimulates natural healing, polychromatic, from 480 nanometers to 3000 to 400 nanometers. No ultraviolet light. Polychromatic means different light wavelengths penetrate the skin in different depths for safe cell activation, accelerated on local blood circulation and systematic stimulation of regenerative and reparative healing and preventive process of the entire organism. Incoherency for force character of biotron light means incoherent light contributes to a safety, non-invasive, painless, and efficient healing process. Please, next slide. Thanks. Biostimulatory effects of biotron light result of synergy of different mechanisms of action. For example, in 400 to 500 nanometer has antibacterial effect. Between 400 to 700 to 18 nanometer, hormonal balance. In range of 400 to 50 to 700 to 18 nanometer, growth factor and immunomodulation effect. In 480 to 750 nanometer, anti-inflammatory effect. And the last, between 780 to 3400 nanometer, systemic microstimulation, microcirculation effect. Please, next slide. Please change. Thanks. In this slide, we watch biostimulative and bioinhibitive effect of biotron light, biological process. First degree, laser light or photonic energy diffuse scattering of laser light on the tissue gives inflammation. Voluminous partially polarized light absorb in primary response in cytochrome nucleus and stimulate the oxygen, chemical energy, and the second part on mitochondria, oxidative metabolism plus ATP production in mitochondria. After that, improved signaling, more increased growth factor, more increased cyclin release, cell-to-cell communication, and macrophage activation, increased number of mast cells, increase protoglycan synthesis, and the second part in pain relief changes calcium ion, potassium ion, and sodium ion, and protein gradient over the cytoplasm. The last, increased nerve cell growth, decrease C fiber activity, pain fiber, afferent pain fiber. And in result, biotron can increase mitochondrial activity for pain relieving analgesic effect, accelerated tissue regeneration, stimulation of cell metabolism, accelerated wound healing, increased lymphatic flow, and stimulation of microcirculation. Please change the slide. Thanks, sir. Photomodulation in human cell means mitochondria are mainly responsible for power supply in cell. Mitochondria, each cell disposes of several of these power stations. Nucleus contains vital bioinformation for intra and extracellular communication, and mitochondria energy reservoir adenosine triphosphate is a form to keep cellular energy. Please change the slide. Thanks, sir. Biostimulative effect of biotron light are the result of synergy between different mechanisms of action. For example, improve microcirculation, vasodilation through production of nitric oxide, improve cell metabolisms, means activation of ATP production. Excuse me, sir. Reinforce the human defense system, means humoral and cell-mediated immunity, stimulates regenerative and repairing processes of the entire body, means increases macrophage and fibroblast activity, increases release of growth factors, increases cellular proliferation. Promotes wound healing, means increased protein synthesis, production of elastin and collagen, and the last relieves pain or decrease its intensity, relieves analgesic, anti-inflammatory, and anti-edema effect. Please change the slide, sir. Biotron phototherapy mechanisms include immediate structural and functional impacts on all circulating blood cells, vital stimulation of growth factors and thus of cell proliferation, improvement of blood microcirculation, increase of oxygen transport and transport functions of local immunity, optimum support of proliferation of skin cells, keratinocytes, connective tissues, fibroblasts, which are forming collagen fibers, vascular cells, endothelial cells. Please change the slide. Thus, benefits of biotron include anti-inflammatory effects, antimicrobial effects, anti-edematous effects, analgesic effects, increased circulation, accelerated healing through the generation of new and healthy cells and tissues. For example, regenerative effect on the skin, leading to faster and better quality and tensile strength of tissue repair, wound healing with minimal scarring, and the benefits in conclusion: no pain, no irritation, no mutagenic or no ionizing effect, no thermal, no overdose, no side effects. Please change the slide. Thanks. Light therapy research references. Also, light therapy research is undertaken worldwide within a wide range of disciplines. For example, biological effects of light, light mechanisms, wound healing, chronic pain, skin and scarring, SAD, seasonal affective disorder, depressions, sleep disorders, natural regeneration, endocrine disorders, immunology, photoimmunology, cosmetology, dental conditions, and energetic conditions. Please change the slide.
Hello.
Please change the slide.
Yes, sir. We can't hear your sound, sir. I think.
Okay.
Yes, you can go ahead.
Can
You
you
can.
listen? Can you listen, my son?
Yes, you can go ahead now.
Okay. Continue. Thanks. Bytron medical light is a safe, medically tested, and clinically approved technology in the management of various sports medical injuries, including tennis elbow, golfer elbow, shoulder rotator cuff strain, tendonitis, calf and hamstring injuries, groin strain, back strain, swelling, spasms and knots, neck pain, pre and post training stiffness, plantar fasciitis, many more. Please change the slide, sir. Thanks. Bytron medical indications in many fields. For example, sport medicine, soft tissue injury of muscles, tendons, and ligaments, muscle spasm, sprains, strains, contusions, and tendonitis, epicondylitis, tennis elbow, CTS, carpal tunnel syndrome. In wound healing after trauma, burns, grafting, wound healing after operations, venous leg ulcers, stasis ulcers, decubitus, pressure ulcers, pain treatment in rheumatology, osteoarthritis, and rheumatoid arthritis, especially chronic condition, physiotherapy, low back pain, shoulder and neck pain, dermatological disorders, and skin problems, atopic dermatitis, psoriasis, herpes simplex, and zoster, superficial bacterial infections, acne, mucosal lesions. In pediatrics, pediatric dermal affections, endogenous eczema, upper respiratory tract infections, allergic respiratory diseases, pediatric musculoskeletal disorders, and neurological disorders and deficits. And in newborns, dermal problems, for example, phlebitis, decubitis, interpterygo, and SAD seasonal affective disorders. Please change the slide. When to use Bytron light therapy, can be used both as a complementary treatment to support conventional medical methods and as a monotherapy for certain conditions. However, we recommend consulting a physician before using Bytron light therapy in order to receive professional advice as to whether this treatment is recommendable or whether other medical treatment is necessary. Next slide, please. Bytron application. Next slide, please. For wound healing, we can use wounds after an injury, post-traumatic wound, burns, wounds after an operation, post-surgical wounds, decubitus, pressure sore, and leg ulcer. Please, next slide. Treatment example, burn wounds, combination light therapy and silicone pressure treatment. Left picture shows us 2 days after submission. The next from left side after 21 days of phototherapy. Third picture from left side, 9 months of pressure therapy, and the last picture from left side, result after 9 months. Next slide, please. Treatment example, deep second degree burn wound. First picture from left side, 3 days after submission. Second picture after 12 days of phototherapy. Second picture, 9 months of pressure therapy, and the last picture, result after 9 months. Please, next slide. Biotron application in a sport injury. Please, next slide. Biotron for pain relief in rheumatisms, osteoarthritis, rheumatoid arthritis, especially chronic phase arthrosis. Physiotherapy, for example, for low back pain, shoulder and neck pain, CTS, scar tissue, musculoskeletal injuries. Sport medicine, soft tissue injuries of muscles, tendons, and ligaments, like muscle spasm, sprains, strains, tendinitis, ligament and muscle tears, dislocations, contusions, and tennis elbow. Biotron light therapy in the treatment of rheumatoid disease can help to relieve pain and decrease its intensity, strengthen muscles and expand body motion, increase walking distance and speed, and improve the quality of speed. Please, next slide. Thanks. Biotron light therapy can help to relieve pain and muscle tightness, improve tissue nourishment, reduce swelling, and speed regenerative processes and wound healing. Next slide, please. Biotron keeps athletes in play because bringing relief to aching muscles, soothe muscle and joint pain, increase the range of active and passive movements of joints, allow quicker recovery of muscular and joint activity, support the treatment of painful sports injuries like tendon problems, muscle problems, contusions, dislocations, strains, sprains, abrasions, bruises, reduce inflammations and swelling. Next slide, please, sir. Application of Biotron light in first step. Before using Biotron light therapy, please clean the area that you wish to treat. Note, any dressing or coating must be removed before treatment. Step 2, relax and point the light beam onto the area to be treated. Hold the device at a right angle of 90 degrees and keep a distance of apex 10 centimeters, approximately 4 inches. The light beam should not be moved during the treatment. Cover large areas by treating them point by point until the whole surface has been covered. Step 3. Apply biotron light therapy once or twice a day, every morning and or evening. For general, 4 to 10 minutes, or according to the instructions of your physicians. Step 4. Repeat above points for each area on the body to be treated. And step 5. Unplug the device after use, please. Next slide, please. Thanks, sir. I present for you some studies about light therapy. For example, ankle sprain. Stasinopoulos et al. 2017 had done randomized control trial for grade 2 ankle sprain. Method, control group number 25, cryotherapy, 20-minute ice treatment every couple of hours for 5 days, and treatment group number 25%, cryotherapy plus biotron, 10 minutes per day for 5 days. Results: biotron treatment, accelerated pain relief, edema reduction, and enhanced ankle range of motion, dorsal and plantar flexion compared to standard treatment alone. Next slide, please. In carpal tunnel syndrome, in pregnancy, dear colleagues, attention please, carpal tunnel syndrome in pregnancy. Stasinopoulos et al. In 2017 had done biotron for pregnant women in third trimester for 25 pregnant women with CTS. Prevalence of CTS we knew. Prevalence of CTS in pregnancy is around 60%. Prior to study, no conservative treatment option available. Method, treatment with biotron for 6 minutes, 10 sessions per week, 5 to 2 sessions per day for 2 weeks. Biotron decrease pain and paresthesia and increase finger pinch strength after 2 weeks of treatment, and effects were maintained after 1 month after treatment. Biotron is safe, reliable, and effective for the treatment of CTS during pregnancy. Please, next slide. Gonarthrosis, osteoarthritis of knee joint. Gorche and Ochizer had researched in 2004 in Romania for 54 patients with knee arthrosis. Conservative treatment with biotron of various duration biotron light therapy slowed the progression of the disease compared to regular physiotherapy in the following parameters: local clinical examination, pain intensity, knee flexion amplitude, true articular balance exam with goniometer measurements, the quality of walking, climbing, and walking down steps showed that. Please, next slide. In the next research, lateral elbow tendinopathy, tennis elbow, Stasinopoulos in 2005. Patients suffering from lateral tennis elbow, 1. Biotron reduces pain and increases function and strength in patients with lateral epicondylitis. In pilot study for 25 patients, treatment of 2 points on elbow for 6 minutes each, 3 per week for 4 weeks. Please, next slide. And the summary: wide range of application in sports medicine and beyond, innovative new technology with clinical proven efficiency and visible results that encourage patient compliance, short treatment times, cost-effective, shortening of hospitalization and rehabilitation periods, reduce overall healthcare costs, no non-side effects, easy to use, used in clinical setting and the patient's home, and continuation approach for rental and home care. Next slide, please. These are references I used for your presentation. And the last slide, please. Thanks to your attention. Finish my presentation, and
Yes.
in this slide is
Yes,
my
this was the presentation from Dr. Sohail. Any questions to Dr.
Thanks.
Sohail? Yes, sir. Any questions? I would like to inform that Dr. Sohail is joining our event since last 4 years. For yearly, he'll be joining for 2 times. Thank you so much, sir. Thank you so much.
Thanks. Thanks,
Yes,
and
you'll be
bye.
getting the participation certificate as well as booklet within a couple of days.
Thanks very much.
Yes, thank you so much, sir. Sorry. The title will be a case of rehabilitation treated with MPR method of biofunctional and posterior rehabilitation.
The MPR International School presents the video of our teacher Gemma Leon Bravo, who will show us a patient treated with the rehabilitative protocol of our school. Enjoy the presentation. Good morning. I am Professor Gemma Leon Bravo, physiotherapist from the Faculty of Medicine, Nursing and Physiotherapy of Cordoba in Spain, and a member of the MPR International team, whose director is Professor Dr. Silverio Duraca. Today, I come to expose a case treated through the method of the MPR and its impact on the tonic postural system. Let's go on to describe the case, and I hope you enjoy. So I am going to introduce our method a bit so that you can understand how we study and investigate posture. So our goal is to take the diagnosis from local to global, and from individual physiotherapy and osteopathic work to interdisciplinary. MPR, or postural myofunctional rehabilitation, is a diagnostic and therapeutic method that uses tools from different health disciplines working as a team to achieve a better therapeutic benefit for the patient. The objective of the MPR is the balance of the stomatognathic, or craniofacial system with the postural tonic system or the rest of the body. Our priority is diagnosis. All specialties intervene with the same optics of diagnosis and treatment. Is rehabilitation because rebalancing all systems. Is myofunctional because is doing a physiological musculoskeletal rebalancing. Is postural because is doing a rehabilitation of the stomatognathic system with the rest of the body. We carry out a clinical, instrumental, and complementary analysis diagnosis. Clinical, we make an analysis of oculomotor system, postural analysis, stomatognatic analysis. Instrumental, posturometry, stabilometry. Complementary biochemical analysis. Intolerances. The treatment protocol used is divided into 3 phases. The first phase, deprogramming of the central nervous system. The sensory deprogramming of the receptors is carried out as follows. The oculomotor system, with proprioceptive magnetic fields. The stomatognatic system, in growth and in adults with body equilibrium device and craniofacial orthopedic. Foot support, with magnetotherapy and plantar deprogrammers. And biochemistry, with detoxification of the organism and integration. Then follows the postural rebalance or treatment itself. And finally the sensory reprogramming. For the oculomotor system, prisms and exercises. For the stomatognatic system, in growth and in the adult with different devices. For foot support, dynamic physio insoles. And finally for biochemistry, intestinal rebalancing, diet, and integration. We are going to give an example to show you the interdisciplinary evolution of a case from the MPR. About a case. 38-year-old patient. Referred by traumatologist with CO of SD. Cervicocephalic. Symptoms, neck pain and headache, dizziness, ringing in the ears, tinnitus, dorsal and lumbosacral pain. For 6 months indigestion and heartburn. Intermittent psoriasis for 6 months. 2012 shingles. For 6 months bad breath, habitual fatigue. Tendency to lose weight. Digestive disorders. Hiatal hernia and irritable colon and intestinal hyperpermeability. Asthmatic in childhood who disappeared. Allergic to pollen, dog hair. And mites that disappeared. Syncope 2 years ago. Amalgams, titanium implants, and root canals. Family history. Maternal hypertension. He is on sick leave, making it totally impossible for him to perform his functions, and he cannot carry out a sporting life that has been progressively declining. Thus, we can see in the lateral view or sagittal plane, a patient with significant rectification of the cervical lordosis, with a significant thoracic hump and both shoulders more anteriorized. Said posture is seen to be affected by retraction of the anterior cervical fascia that affects the hyoid position, as seen on the X-ray. Tension in the masseter and temporal muscles is also visualized. Upper jaw forward to the lower. Hump attitude and chain closure anterior. In the anteroposterior view, a right thoracolumbar convexity deviation is observed, with a higher right shoulder and left pelvis. It can be observed at the sagittal level due to the same retraction of the anterior chain. A bilateral flexion of the hips causing a postural attitude with slight triple flexion of the MMAI. The convergence test shows bilateral hypoconvergence consistent with bilateral TMJ dysfunction. That is why the differential test, in which we annul the TMJ occlusion, is corrected and converges perfectly when we correct the bite. Hence the direct relationship of the TMJ at the postural level with the oculomotor system. In the arm extension test, it is observed that there is a difference in the length of MMSs. The left arm is longer, and after correcting the bite and balancing it with cotton rolls, it is observed how they are regulated and homogenized. In the left and right rotation test, as well as flexion extension, limitations were observed, especially in left rotation and cervical extension. An alteration in foot support is also observed, with a bipodal valgus and flexion of MMII in both knees. Also, the left foot falls more in valgus than the right. In the march test, the patient walks forwards and to the left with his mouth closed and to the right with his mouth open. In the slide with the patient seen from behind, greater internal rotation of the MID is observed, and the greater elevation of the right cheekbone, in addition to greater anterior elevation of the right shoulder. In the photo to observe the short leg, the left one looks shorter. In the bite, the upper jaw is more advanced than the lower jaw and with a great imbalance of the bite on the right side. Regarding the left, observing laterality to the left, we see again the relationship between the imbalance of the bite with the cervical rectification and the anteriority of the bite. Here we can see the comparative image of the patient's mouth and the lateral X-ray. The treatment protocol was as follows. First, osteopathic and craniosacral deprogramming. Occipitedlantian epistropheus complex. C0, C1, C2. Action on the different cranial sutures, sphenoid, frontal, zygoma, upper jaw. Action on orbital sutures, zygomatic frontal, internal sphenoidal suture, maxillary suture. Second, chain reactions, hyoid system. Third, postural functional deprogrammer body equilibrium device for craniofacial system. Annulation of the negative action. Fourth, biochemical deprogramming. General detoxification and heavy metals, cilantro and chlorella. Food intolerance and increased intestinal permeability. Reprogram, biochemistry. With diet and intestinal rebalancing, the patient underwent a food hypersensitivity test to gluten, fatty fish, milk, egg, tomato and rice, pork, chicken, and beef. After deprogramming the patient, receiving his treatment for 1 year, and reprogramming it, here are the results. Better mandibular position in the more centered anterior view. There is cervical lordosis and its center of gravity is better traversing the patient's midline while being less flexed. There is also a better balance of the shoulder girdle with respect to the pelvic girdle with respect to the sagittal plane. The patient's muscular defense is more evident. In the next slide, the greater tone is observed in the trunk extensors, evidencing greater balance with the anterior chain and better accommodation of the scapulae, as well as a better position of the thoracobrachial triangle. In the following radiological slide at the anteroposterior level of the spine, a decrease in spinal deviation and better positioning of the TMJ is observed, in addition to better postural balance in the pelvic and scapular girdle. The following X-ray shows the patient with a greater anteroposterior volume at the level of the thorax, with a more balanced posterior chain than the anterior chain and a balanced center of gravity with a preserved cervical lordosis and a better positioned and balanced gaze with the bite. It must be said that the patient's biochemistry improved remarkably, his colon being non-irritable and tolerating almost 100% of the food. Sporting, he returned to do all his sports and returned to his working life without a problem. Thus, it can be concluded that the patient recovers his quality of life and obtains 100% of his functionality, observing the MPR as a highly effective form of diagnosis and therapy. I hope the presentation has been useful. Thank you for your attention, and follow our courses at the MPR International School. Send your questions by mail and we will answer them with pleasure. and we will surely see you at the next event.
Yes. This was a presentation from Dr. Jamal Leon from Italy. If you have any questions related to this topic, just you can text us. Even Menam is in online. Any questions related to this topic? Any questions? So thank you so much, madam, for joining this event. I would like to inform that Dr. Silverio Di Rocca is encouraging all our speakers, especially from Dr. Gima Leon from Italy, Dr. Giuseppe from Alicia from Italy as well, for joining this event since last 2 years. And next we asked Dr. Tracy Wilson Kison from Physiotherapy from United Kingdom. Yes, madam, you can start sharing your slide from your side.
Hello. Hello,
Yes,
good
ma'am.
morning. Can you hear me?
Yes, madam.
Because I can't see anything other than my screen. Okay, hi, good morning. So thank you for inviting me today. I'm really keen to get this to be as interactive as possible, okay? Because this will help you understand what I'm saying, okay? Is that okay? Can I have a yes
Yes,
from the
it's
chat?
yes, it's okay, madam.
Okay, so I want to talk to you about the changes to the brain in chronic pain. So to give you a little bit of a background, I have 33 years of working as a physiotherapist, and I've been working really with chronic pain for the last 10 years. And I'm currently about to start some research at Keele University to access the vagal nerve using a TENS machine to help people with fibromyalgia deal with some of their symptoms. Okay? So just to give you a little bit of context, currently in the United Arab Emirates, your back pain percentage is going up and up and up. So that's some people say 80%, but the statistics that I came across said 60%. Okay, so and we're talking a very young age. I don't know if you can see that, but this is only going to become a problem. This chronic pain is only going to become this pain is only going to become more of a problem as time goes on. I hope not, but I'm just saying. So in the UK, we have a real problem here. Listen, look at those statistics. Long-term back pain, 20% of adults over 18, and those over 45, 3 to 4%. But look at the cost here. We're talking 10 billion English pounds, which is about 15 billion US dollars. Okay, so that just gives you an idea. And I just put that in as a little bit of a flavor. So we're talking chronic pain. Okay, so chronic pain, it's not your normal, oh, I've got back spasm for 2 weeks. It is people that have recurring symptoms. They just cannot seem to get rid of their symptoms. And so before the International Association of Pain described pain as just something that goes on for more than 3 months and then it becomes chronic. But as you can see from the slide, associated with or resembling that associated with actual or potential tissue damage. So we know that the way the central nervous system works is that you can have no tissue damage and you still experience pain. Are any of you familiar with this idea? Because it's quite tricky. So now we know that there are more dimensions to chronic pain than the actual pain. And this is really the focus of this talk, okay? I want to bring up what happens to the brain and why that's important, okay? So in the last few years, some of our eminent neuroscientists have decided, so there's been a lot of research around the inflammatory pathways and what happens at the dorsal horn, but actually there are changes in the dorsal horn, but also there are changes in the brain. Now, these two, I would call them the big guns. There are many more, but really they are both saying the same thing, that it is about a memory, and it's also about the fact that the nervous system has become over-adaptive and overprotective. And I want you to hold those two things in your mind, because we know that memory and maladaptation of the nervous system. Okay, so I want you to think about those two things. Okay, now I just want to tell you a little bit, just to give you a flavor of what I mean. So I will interject my own story, and I will tell you about patients also. So about 15 years ago, unfortunately, I had a 20 stone, I don't know what that is in kilos, over 100 kilos. No, more like 200 kilos. A lady who landed on top of me. It was a neuro rehab patient, and the wheelchair failed, and she just squashed me, basically. So this was back in the 90s, when I didn't have that much faith in. I was a chartered physio working in the National Health Service. So our health and safety probably wasn't that great at the time, I'll be honest. And I developed, unsurprisingly, some back pain. And I had it treated, and it went, but there were a lot of contextual factors around that. And by that, I mean that I didn't get much support. Everybody tried to shut down the story of what happened because it reflected badly on them. It reflected badly on the department. It was a very good North London hospital. So for confidentiality's sake, obviously, I'm not going to mention it. But my point is, I was a bit traumatized, and I just needed somebody to talk to me about why did I protect her over my own, or just get a little bit of emotional support. Anyway, fast forward on getting problems. So that first problem didn't resolve itself fully, pretty well, but not fully. And then I was doing some kind of yoga workshop. I tore my abdominals. So that was another layer of the issue. And then I hurt my thoracic spine. Surprise, surprise, because that was doing all the work of the low back. And so it went on. And 10 years later, I found myself with, I had periods of pain-free. Of course I did. I had periods where I was absolutely fine, and I had periods where I was not fine. But ultimately, I ended up with poor sleep, feeling a bit brain foggy, feeling emotional, and just not myself. And I want you to hold those, because in that, I want to explain what happens to the brain. So people that have experienced pain for more than 3 to 6 months, usually in the context of some stress or some difficult life things going on, their prefrontal cortex shrinks, their grey matter shrinks. So we no longer have access, and I say we because I used to be that person, we no longer have access to our logical, rational brain. Okay, so this may be why your patients are so emotional about their pain. I mean, it is a sensory experience, it is an emotional experience, but for them, it is everything. You find them catastrophizing, ruminating, and that's partly because of this. In a couple of the later slides, I've included what those structural and biochemical changes are. I just feel that if I keep this presentation succinct, you can hopefully be interested and go and read from all the list of references that I have. But this is a personal and professional, and now I'm a chronic pain specialist because what I've been through, and that because it's such a problem. Okay, prefrontal cortex, then the amygdala. Now, as you probably know, the amygdala forms a very, very key part of the limbic structures, and it basically enlarges because more and more nociception, which is not the same as pain. Nociception is the pathway, it's the information that does not need tissue damage for it to convey the messages. And that's the key bit here, the key bit of information. And so the person doesn't have access to their logical brain. Their amygdala, which processes the fight part of the fight, fight, freeze, becomes bigger. So therefore, it becomes much more efficient at detecting problems in the body. And everything ultimately, long term, gets processed as a painful experience. And this is the danger with people who get into the chronic pain cycle. It is a cycle, they can get out, okay? But the next time that you see somebody that has been struggling for 6 months, a year, a couple of years, I hope that you go back to this and remember this, because this will enable you to treat them more effectively. It is not about the body part. The hippocampus, again, this forms a very important part of the limbic structures, and it has very close anatomical connections to the amygdala. And for that reason, it changes how it reacts and how it responds. And so things that you wouldn't think become connected via the hippocampus and amygdala and their interactions. And so strange things will set a patient's pain off that they wouldn't know was connected, and neither would you. And so just understanding that can give you better awareness, I would say, of what's going on. Right, this is another big one. These are the like big 5 or 6, okay? So interoception, I don't know if many of you have heard of interoception. So interoception is the brain internal, or the central nervous system, should we say, its internal mechanism for detecting what's going on in the body. Things like heat, temperature, comfort levels, probably electrolyte balance, and a few other things. This becomes altered. This is another big one, because then the body's own internal systems start to work against this poor patient that you've got in front of you. Yeah, so that everything becomes a painful experience, actually. A change in the weather, them feeling cold or tired. You would have heard this over and over again, and maybe not be able to make sense of it. So hopefully this helps you make sense of what they're saying. And there are a lot, I've given you some references, there are a lot of very good references to read up. And the other big change, I would say, and there are conflicting opinions about which part changes and how it changes, but I think I just want to leave you with the core issues. It's up to you if you want to academically debate it. These are a given. These are changes. Specifically how, I haven't gone into, because I want you to make sense of the science with the person in front of you. For me, that's my passion. That's how I treat people. That's why I've deliberately kept this presentation not basic, no, but the core issues, I would say. Okay, and the last one that I'm talking to you about is alterations in the default mode network. Now, this is very interesting, and I can't help it, but I'm going to tell you a story about a gentleman who came to see me about 18 months ago, and he demonstrated these changes in the default mode network brilliantly well. Actually, he demonstrated all of them really well. So he came to see me, and I could see that his prefrontal cortex, He had difficulty. He forgot his glasses. He didn't know. He asked me 7 times before he arrived what time his appointment was. In the end, his wife intervened and she wrote it down and phoned me. This is all within the hour of him coming. He clearly was anxious when he came in. And that's, I refer to number 2 there, the amygdala enlarges. He was on freeze. He just could not even converse. He could barely write his name down. When I asked him about the history of how he got in for the situation that he was currently in, his hippocampus failed him. He couldn't, memory and learning, it had changed. He just could not put together a coherent story. Okay. And his interoceptive facility. So he was always too hot. He said he was running too hot all the time. And if he got too hot, that would make him flustered. So this is number 4. And he would start to feel more pain. So I think that's a really good example of his interoceptive facility failing so clearly for me to understand and see. And then 5, that's more subtle. That's, social understanding of yourself and your own behavior. So I think he showed this by, I would send him information or questionnaires in between him seeing me, because basically I was coaching him. I was using CBT, and I was using some muscle stability work with him. I was using some acupuncture to help calm the nervous system. But on the whole, you have to be really careful with these patients. You want to be hands off with them, because if you do too much touching around the body part, there are other things. The matrix also becomes sensitized, and the sensory motor cortex changes and enlarges. That's sort of a given within physiotherapy. We know that if you have pain in the hand, the area maybe around the wrist is a bit tender also. But long term, this means any sensory input around the area that was initially the problem, it can all signal danger. I must put that in as number 6. I'm sorry, that's like really important. But I like these ones because I think they're ones we don't come across very often, or that we don't think about them. We just think the patient is strange. We do in the UK. And I think the fact that I would often have to say, we have finished the session now, could you please get dressed? And then he would need me to then say, right, okay, it's time to rebook. I have to, every time he saw me for 3-4 months, every single time we would have to go, because he could not put himself in the situation and understand what was socially appropriate behavior, number 1. Number 2, when I would send him information, he never, ever acknowledged that he'd received it or read it or did anything with it. And then when we came to sort of reassess how he was doing, the thing that helped him really understand that it was his central nervous system over processing is that he had some stress around his wife's health. And he was going really, really well. We were using the CBT. We were doing some acupuncture to calm his nervous system, get him into the relaxed place, and get him moving again. Everything just ignited again, and we went back to square one. Now, he got very upset, understandably. He thought it had all come back, or he'd re-injured. And it helped me explain to him about the pathways, about how our central nervous system processes pain, and then these changes that take place, and that the tissue injury can have already healed, but because of, we're not always sure of the factors, but usually it's trauma in early youth, it's stresses and strains, repeated injuries. The amygdala just does its job and anytime anything happens with or around that area, it kicks off the whole sequence again, and you get facilitation of the pain processing instead of defacilitation. I can't remember what the word is now. So the pattern just keeps on going without tissue damage. And so our job as physiotherapists is very much, I think, to there's a nice slide here about the changes, and there's some lovely references. I think we have to remember that patients are really, really frightened, okay? And if we can be calm and understand what's going on, and I hope this is not teaching you to suck eggs, but this hopefully will spark somebody in the room to be really interested in chronic pain, because the medical profession hasn't got all the answers. They haven't got the answers, and it's tipping more into psychology. So that's why cognitive behavioral therapy is very useful. And recently there's been quite a lot of work around something called extinction training. What that means really is, if you remember at the beginning, I talked about Vania Apkarian, basically very, very distinguished neuroscientist, said that pain was a memory that could no longer, or the fear could no longer be extinguished by our normal set of circumstances. Okay, Laura Mosley, which some of you may have heard of, he's written a really good book called Explain Pain, or Graded Motor Imagery, Explain Pain, Supercharged, and it's really written for patients. There's lots of pictures, and it's just really useful, and it's great for anybody dealing with chronic pain, the medical doctors, physios, psychologists, because I think sometimes we forget that these people are operating in a constant, they're just constantly stressed and afraid. Because if you go back to what I said with those 5 major points, they are no longer operating with executive cognitive function. They aren't. They are they're on fight, flight, freeze all the time. So they are stressed. They are on a bit of a hamster wheel. So helping them see that goes a long, long way to helping them. And either us physiotherapists are going to have to get a lot more skilled at CBT and learn extinction training, which currently is only in the hands of psychologists, and there aren't enough physios in the UK doing CBT, and there aren't enough psychologists helping. So these people are falling in a gap. Like I say, I'm actually learning CBT and with a chap that wrote about extinction training. I'm going to train in that area because I feel like it's my passion, having been there and having been in such a difficult position with chronic pain. I would like to do something to help, and I hope that one day I'm teaching other people what to do. Okay. Any questions?
Just one. Hello. Any
Hello.
questions? Yes. Any questions?
I was deliberately not too scientific, I hope that I married some of the neuroscience with what you see in front of you when you see patients. Does anybody have patients that come back to them time and time again?
Yes. If you have any questions related to this topic, you can text us.
Please do. I've left my email address there. Hopefully I'll talk about the research, and I hope it's published and you guys can have a copy. I'd be very happy about that.
Yes, yes, definitely. Thank you so much, madam. You'll be getting the participation certificate as well as booklet within couple of days to your email ID.
Okay,
Yes.
all right. I think I finished early. I must be the first one. I probably raced through that at 100 miles an hour. Sorry about that if I did. Is this recorded? Is this recorded?
Yes, yes. You'll be getting the link as well.
Okay,
Record
so
only.
thank you for inviting me. I'd love to come back again.
Thank
Take
you.
care.
Thank you so much. Thank you so much, madam. Have a nice day. Bye.
You too. Bye.
Next, we'll go with Dr. Camila Shirile from University of Sao Paulo from Brazil. Yes, madam. If you are, yes, you can go ahead by sharing your slide.
Hi, okay. Hi, can I start my
Yes.
presentation?
Yes.
Hi, dear colleagues. I'm talk about device and non-device guided slow breathing to reduce blood pressure in hypertensive patients, a protocol of systematic review and meta-analysis. I'm a physical therapist. I'm from Brazil, and I'm member of European Society of Cardiology.
In Google, it's showing 150.
Hypertension is a multifactorial chronic disease and the main risk factor for development of cardiovascular disease and the chronic kidney disease.
This time we don't have time.
It affects 32% of adults and more than 60% of the elderly, being responsible for half of the deaths from cardiovascular disease in Brazil. In addition, its complications can lead to decreased work productivity and family income. In Canada, hypertension affects 23% of the adult population. In the United States of America, 12% of adults have blood pressure values greater than 160 for 100 millimeters mercury. On the European continent, the disease affects 30 to 45% of general population. Treatment of hypertension. Considering high prevalence rates of the disease, the treatment of hypertension is necessary not only to reduce BP levels, blood pressure levels, but also to prevent the development of cardiovascular diseases and kidney diseases. This treatment can be medication, which will be determined according to blood pressure levels, within medical consultations or at home, cardiovascular risk factors and the presence of target organ damage identified during anamnesis. 1 minute, please. This treatment, sorry. Non-pharmacological treatment. Non-pharmacological treatment has also been shown to be effective in reducing blood pressure levels in patients with hypertension. Among them stands out the body weight control, the establishment of healthy eating habits, reducing salt consumptions, more specifically, the alcohol consumption control, the smoking cessations, the stress control, aerobic and isometric physical exercises, and slow breathing guided or not guided by devices.
Thank you.
Non-pharmacological treatment and physiotherapy. The physiotherapy prescription for the treatment of hypertension may include both exercise and device guided slow breathing or non-device guided slow breathing. This breathing exercises consist in slow and deep breathing, 6 to 10 breathing per minute, and it can be done with or without device that guides them. Concerning practice of exercises, isometric exercises have been shown to be effective in reducing the blood pressure levels, as well as aerobic exercises and dynamic exercises. So, physiotherapy and slow breathing. Since it activates cardiac and pulmonary stretching receptors, decreases sympathetic activity, increases parasympathetic activity and vagal tone, changing heart rate and blood pressure, and it would be clinical sound to consider that it reduces blood pressure levels. With the blood pressure reduction, there is an increase in bioreflex sensitivity, which promotes improvements in the autonomic balance of hypertensive patients. So, the systematic review was carried out with the objective of summarizing the effects of device-guided slow breathing on blood pressure levels of hypertensive patients when compared with control conditions such as minimal intervention, usual care, placebo, and no treatment, compared to other interventions like non-device guided slow breathing and used as adjunct to other treatments. Research question. What is the impact of prolonged use of device or non-device guided slow breathing compared to usual care on the blood pressure values of hypertensive patients? Systematic review design, systematic review and meta-analysis of randomized clinical trials. This systematic review was inspired in the recommendations of Cochrane Handbook of Systematic Reviews and the preferred report items for systematic review and meta-analysis, PRISMA. Type of studies. Randomized clinical trials, RCTs, published up to January 2020 were included in the systematic review, without the language restriction and the year of publication. PICO, participants, hypertensive patients with or without comorbidity, over 18 years old of both sexes, with or without hypertensive medication. Intervention. The selected studies showed comparisons between groups that performed the device-guided or non-device-guided slow breathing with control conditions. Outcomes. The primary outcome was the value of systolic blood pressure and diastolic blood pressure after the interventions. The secondary outcome was the reduction in the quantity dosage of drugs administered to control hypertension. There are many exclusion criteria. RCTs that also use the other interventions along with device-guided or non-device-guided slow breathing, such as physical activity, salt reduction and salt substitution, stress control, dietary, low lifestyle modification, smoke cessation, alcohol restriction, sleep, were excluded since it was not possible to identify the specific effect of device-guided or non-device-guided slow breathing. We researched on PubMed Medline, Lilacs, and Basic, Cochrane Central, Pedro, Sinol, Scopus, Web of Science, Livivo, CityGov, and Great Literature. Assessment of characteristics of studies. Cochrane risk of bias tool for randomized trials, ROBI2, was used. Data analysis. All data from continuous variables referring to blood pressure values in millimeters mercury were synthesized. Used the mean difference method with their respective 90-50% confidence intervals, and the standard deviations to analyze were also extracted. The effects of intervention on blood pressure values were analyzed separately. The data were evaluated according to the type of intervention. However, only studies lasting at least 8 weeks were considered for meta-analysis. Results where there was intention to treat analysis were used whenever possible. The presence of statistical heterogeneity between RCTs was assessed using the I2 statistic. The quality of the evidence was considered inconsistent if considerable heterogeneity between the groups was observed. When sufficient evidence is available, funnel graphs were to be used in order to investigate possible publication bias. Data synthesis, we used the grading of recommendations, develop an evaluation grade. Results. As of December 2021, the review is completed, and this is a protocol, okay? And this review is complete, and all data from continuous variables referring to blood pressure values have been synthesized. Discussion, conclusion. This systematic review aims to provide the best available evidence of the effectiveness of device-guided and non-device-guided in patients with hypertension, as well as device-guided and non-device-guided allows for reduction in the amount dosage of antihypertensive medication administration. It is believed that the results of this systematic review will be important because both device-guided and non-device-guided slow breathing are accessible and can be performed even at home, as long as the use is prescribed and guided by a physical therapist. In addition, this review is the first to assess non-device-guided unrelated to effect of pranayama on the blood pressure of patients with hypertension, since this type of intervention is routinely used in physiotherapy's clinical practice, following a completely different method from the adopted in yoga. Therefore, this evidence will inform healthcare professionals and patients about the potential benefits of this intervention. This review may also identify gaps in the literature that can be addressed in future studies. This is the reference, and thank you.
Hello. Any questions? Any questions to Dr. Camille? Any questions? This was a presentation from Dr. Camila from Brazil.
Thank you.
Yes, we are expecting your presence for next year in person at Paris, madam. Next year we are going to organize in Paris. Okay. Yes, you will be getting its participation certificate as well as booklet within a couple of days. We have successfully completed on day 1 as well as day 2 of the sessions. Yesterday we have started our programs this morning, early in the morning, started with Professor Kadim Halbi from UAE and concluded still Lakshmi Devi from Government of Sharjah, UAE. And today we have started our sessions from Dr. Manisha Hayrat from Physiotherapy from India and concluded with Dr. Camila Shirley from Brazil. Kindly note, you will be getting in the participation certificate as well as booklet within a couple of days, including the CPD points as well. We are very much thankful to all the speakers who are responded so well to our mails, and especially thankful to Mr. Bhuvati as well as Mr. Kevin, who have worked since last 7 to 8 months to organize this event. Thanks. So thank you once again. If you have any questions or comments related to this topic, this physiotherapy conference, you can text us or mail us. Immediately, Mr. Kevin be mailing you all officially to all the delegates. Thanking you so much. we are going to conclude the Congress. Thank you so much once again.